Hi, this is Dr. Kolodenker, and I wanted to go over today on the intricacies of doing an ankle fracture repair, the knowledge that's needed, some surgical techniques, and what you can expect in the recovery process. So in an ankle fracture you have the fibula and you have the tibia, which are what breaks most of the time in a fracture. There are different mechanisms of injury. Most commonly the fibula will get broken, and there's different types of fibular fractures. What's important is to know how the fracture occurred, because it'll help you to put the bones back together. The better the bones can be placed back together, the better the recovery. So part of the recovery process is anatomical reconstruction of the ankle, which is very much needed in order to prevent post-traumatic arthritis. Sometimes post-traumatic arthritis will set in no matter how good the surgical technique is. It's just the nature of the injury. The more severe the injury, the greater the chance of post-traumatic arthritis, but we try to do our best to recreate the anatomical alignment of the bones to prevent that from happening. Also, is going to be important is early range of motion. So it's very important to have good internal fixation, good rigid fixation. I like to use locking plates, which allows me to range the patient a lot quicker. Moving the ankle up and down will prevent scarring, thick scars on the inside, and limited range of motion and freezing of the joints. The medial malleolar fracture can also be repaired if it is broken by putting screws throughout it. Very rarely are plates needed on this side, but sometimes it is needed. Sometimes with more comminuted fractures, more intra-articular joint fractures, I will also use ankle arthroscopy to actually look inside the joint during surgery and make sure that everything is aligned perfectly. If this ligament that runs all the way up here is torn, a screw gets placed across here called a transsyndesmotic screw. That stays in for several weeks, and a lot of times it needs to come out. Sometimes new technologies allowed us to put things like tight ropes, which is a thick string that goes across here, which a lot of times doesn't need to come out. And then the debate about whether the screw needs to or does not need to come out is sort of written up in the literature. Sometimes when you start moving, the screw can break and cause irritation as well. So in my opinion, it should come out in about 10 weeks after being placed. Timing for surgery is very important. If there's a lot of swelling right after the injury, the soft tissue envelope is going to be compromised and have a higher chance of dehiscence. So it's very important to get the swelling down or do the surgery right away. If you give a chance for the soft tissue to calm down, that'll be very good. Putting you in a posterior splint or some kind of an A-strap bandage, keep it elevated, ice, all those things are very good. Try to refrain from taking any non-steroidal anti-inflammatory medications like ibuprofen, Advil, Motrin. If you have pain and you're able to take Tylenol, by all means Tylenol or ice will be much better. The non-steroidal anti-inflammatories will and can slow down bone healing. So for instance, if you ended up just needing casting without needing any kind of surgery, then you really want to refrain from taking any non-steroidal anti-inflammatories. Speaking of casting, what is my protocol for casting? Typically, a displacement or motion of less than 2 millimeters will allow healing where the bones can come back together. If there's more displacement, if there's extra space, then you really want to fix it. Typically, what I notice in my hands is patients get better quicker, faster, with more predictive results when I do surgery. I can realign things a lot better. We can range the ankle a lot quicker. If we were to put somebody in a cast, that's immobilized for several weeks, whereas after surgery, we basically start moving the ankle almost the next day. Within a week, definitely, the ankle is being moved up and down and physical therapy is started. Early range of motion is extremely important for my athletic patients because they need to get back out running, jumping, just being active a lot quicker than the casual elderly person that would get away just fine with just a cast. With that said, if a cast is perfectly fine, I have no problem putting on a cast on a patient with very minimal displacement, because going in surgically is not always what's required.